both nurse practitioners, and I am a board certified family nurse practitioner, and we both practice telehealth. We both do very, very different things. And so Christine does hormone therapy. She does specifically with perimenopause, menopause, all those hormone changes that women go through. And that certainly is not my specialty. And so I wanted to chat with her today about what she does, about just to clear some of the air about the myths and some of the truths about menopause, how it affects our not only our hormones but our weight, and why we feel like we can look at food and just gain weight. So, Christine, go ahead and introduce yourself and let's get started.
Yeah, so I'm Christine Grumping. I'm a nurse practitioner and I'm specialized in menopause care through NAMS. And so, yeah, when I got started as a family nurse practitioner, just like you were saying, Nicole, I wasn't that familiar with menopause, which is crazy considering how many of us, right, will go through it. And, I couldn't find any colleagues that were really familiar with how to treat menopause. And I just thought, this is crazy. This is such a big company and nobody knows how to treat menopause. And so I was like, okay, I'm going to become certified in this so I can help our patients. And then I really just fell in love. I
I love
call
that.
myself a menopause enthusiast, right? Like there needs to be some of us out there so that we can spread the word about what to expect. So I think like most patients, I thought, oh, you go through menopause after you stop having your period, and that's when the symptoms happen. But what I've learned and through working with clients is that that's not how it really works. For most women, you start to have symptoms during what we call the perimenopause phase. So, so that we're all using the same terminology, perimenopause is just the phase before you stop having your period. So 12 months without a cycle is considered menopause, right? And so a year after that, you're in the postmenopause phase. And so perimenopause is the time leading up to that, and that can last 10 years. So for most women in the United States, you're looking at menopause between the ages of 45 and 55. So on average, that's like 51 to 52. And so perimenopause can really occur anytime leading up to that. So a lot of the women that I see are in their early 40s, mid 40s, and they're having symptoms. So that's the common presentation. And I think the biggest red flag, or I should say the most common thing that I hear when someone comes to me is they say, I went to my primary care, I went to my OBGYN, and my labs were normal. My hormone labs were normal. And so, they just said, go home and, come back when you stop having your period. And so that's really common. And I always like to start with educating that we don't need to check hormone levels to diagnose perimenopause or even menopause. So
Wow.
it's a clinical diagnosis. Yeah. So that's like one of the first myths, right? Is that you need abnormal labs to diagnose it. So the reason why labs are really not that helpful is there's only a small window where you're going to catch an elevated FSH. But for the perimenopause phase, it's going to be variable. And the same is true with estrogen levels. So what's happening during perimenopause is your estrogen levels are going up and down, and it's that fluctuation that causes symptoms. So unless you're checking every day, you're just not going to get that picture. And often what you'll see is maybe a high estrogen level as opposed to low. And so symptoms aren't related to your hormone levels. And so that's why we
Wow.
don't use them to
Wow.
diagnose. Yeah, and we don't use them to treat. So that's myth number one. Don't need levels or labs to diagnose, and we don't need them to treat. And so from there, it really is just a history. I would say we can start with who should be on hormone therapy, right? And so FDA indications for hormone therapy would be hot flashes, night sweats, and osteoporosis prevention. So those are what I follow Jen Gunter, and she has a green light, yellow light, red light system, and that's what I use to explain this model. So those are the green light reasons or indications to start, as long as there's no contraindications, and we'll get into what that looks like. And there's very few, by the way. Now, yellow light could be something like low libido, which is pretty common in this phase, right? And so that's what we would consider yellow light, where it wouldn't be wrong to try hormone therapy. Typically, you would do a 6-month trial. And if there's improvement, that's a really good indication that that treatment's working. And if it's not, and it indicates, let's reevaluate and see if there's something else going on. Some other ones that are in that yellow light would be like depression. There's a lot of really great research that shows that you can use hormone therapy, so estrogen and progesterone for women with a uterus. You always want progesterone, so you could use that to treat depression. Now, of course, if it's severe depression, you would always want to use other medications, not just the hormone therapy, right?
Right.
And so, again, just having that discussion, ideally with somebody who's certified in menopause, so you can talk through all those symptoms, because I think, myth number 2, hot flashes and night sweats, that's not the only thing that happens during this period, right? There are a lot of symptoms and it's going to look different for everybody. And so, it may be sleep disruption for you, or it could be, like we said, mood changes. Vaginal dryness is another really common one. So that journey of menopause is very individualized. And again, it's why it's so important to have this conversation.
I did not know. I knew you could diagnose
Yeah.
with a clinical, like with just symptoms, but I did not know that it would also help with other things. And something I want to ask about is vaginal dryness. Does that have a color? Because I get that complaint a lot of the vaginal dryness. And does that have a color?
Yeah, vaginal dryness. That's a really good question. So, the standard of care for any woman with vaginal dryness would be vaginal estrogen cream or tablets. And really, the difference there comes down to preference. With the cream, it can be messy. Some patients don't like that aspect of it. And with tablets, you can travel with it. So, that's another plus. If you're doing a lot of travel, you can travel with that in your carry-on, not as messy, right? They will both treat vaginal dryness, and you don't need progesterone with it. There's no risk of endometrial cancer with that. And so I know it comes with the really scary insert. That insert about estradiol and those risks are with all estradiol forms, but it really doesn't apply to vaginal estrogen cream or tablets. So we have a lot of great high quality studies that show that it's super safe and effective. And those risks of like clots and breast cancer and endometrial cancer, yes, breast cancer and endometrial cancer really don't apply to vaginal estrogen therapy.
Really?
Yeah. And it's crazy because I've worked in OBGYN clinics and I've had providers who are scared to prescribe it, but it's very safe. It really comes down
Well,
to the
I'm one of
W.
them. Like I'm one of them.
Yeah.
Honestly, I am nervous to prescribe because I'm scared of all this because I just don't know.
Yeah.
Like I just don't
Right.
know.
No, totally. And that's what I was going to say. It comes down to the WHI study that they did. I think that was in 2004, that really scared a lot of providers and patients. And unfortunately, the study was really skewed. Most of the women were starting hormone therapy after the age of 62. And that's just not, I mean, we talked about the average, right? It's 44 or 45 to 55. So that's not the population that's going to be starting hormone therapy.
Right.
And so from that study, showed increased risk for heart attack, stroke, breast cancer, endometrial cancer. It was ultimately why they ended it early. The study was intended to show that hormone therapy improves cardiovascular outlook, which we do have some studies that it does, but their population was the wrong population. So you can't apply it to the general population, right? And so what that study did highlight is the timing theory, that when you start hormone therapy is really important. So it should not be started in anyone over the age of 60. This doesn't apply to vaginal therapy, right? So vaginal estrogen therapy is fine, but oral or systemic hormone therapy should not be started in anyone over the age of 60 or their period more than 10 years ago. So for that age group, there's no benefit, there's more risk, right?
Yeah. Wow. That's so interesting. So for
Yeah.
women who today, who let's say they are in that elder age group and they have been on it for a long time, is your recommendation, and I know it's very patient specific, would you as a provider continue their estrogen therapy once they hit 60 or 65? Or would you say you don't need it?
Yeah, that's another really great question. So I was just watching the NAMS conference from this year, and they talk about this every year. And the most recent NAMS position statement, which is a good guideline if anyone wants to know the treatment. And so what they said is there's no age that we just cut you off. So your risk doesn't inherently increase from 59 to 60 if you're already on treatment, right? So we said, we don't start it in anyone older than 60, but if you're already on hormone therapy, that's a different category. And so it would be safe to continue as long as a provider, you want to continue to have the conversation of the risk. So looking at their ASCVD risk score, right? And if it's greater than 5%, then you may want to talk about switching to either a patch or continuing the conversation of non-hormone therapy options. But really, if their risk is low, so their cardiovascular risk is low, and they have one or less, we can talk about with this one or less chronic condition that increases their cardiovascular risk, they're really in a safe population to continue using that treatment. It really is like it's a very patient-centered approach where we talk about, is treatment still helping you, right? Like, why are we still using it? And have we tried maybe decreasing your dose to see if that lower dose is still maybe treating the hot flashes or whatever the reason that they're using it for? Because even if it's for osteoporosis prevention, we can still get the benefits of that at the lowest dose, which is the 25 micrograms with the estradiol patch. And so you don't have to be on a high dose to get those benefits.
Wow, that's really cool. That's really good. That's really good
Yeah.
information. Well, thank you for sharing that. And we'll have more
Mhm.
questions, I'm sure, because there's so many women in this population. And for me, it's not something, like I said, it's not something I do. So I will refer to OBGYN, PCP. I'm like, I don't know, but I would love to refer patients to you. So how can patients find you?
Sure. Yeah. I mean, so the first thing I always tell patients is go to the NANS directory.
And what does that stand
And
for? What does that stand for?
so Menopause Society.
Okay, national. Okay, okay, gotcha.
So the NAMS directory, and you can even just search NAMS providers, and it will pull up their directory where you can search your state, either in person, or I usually recommend telehealth. You're going to get more results that way, and you can put your state in, and it'll pull up all the providers in your area. So I'm listed in every state where I provide care, which is quite a few. I think I'm up to 30 states now. And so they can go there to find a menopause certified provider. It's important to note only 30% of OBGYNs receive any formal training in menopause. And so most of them don't feel comfortable in this area. And it's not to make primary care providers or menopause providers wrong, right? It's just unfortunately not really included in our medical training. And so it's only providers who actively seek additional certifications that are going to be really knowledgeable in this area. And it changes every year. So it really does take a lot to stay up to date on the guidelines and the recommended treatments because, things are always changing in medicine.
Wow, wow. Well, that's awesome. That's awesome. All right, guys. So thank you for joining us today. This is just a little bit of I feel like this is just the ice tip of what, Christine has to offer. And I definitely would like to revisit this again. So thank you for joining me today. Patients, we both do telehealth. Like I said, I'm licensed nationwide. I do more urgent care, more bridge care, things like that. Whereas Christine, she does a lot of things, but definitely specializes in this. So you can find me at hamiltontelehealth.com and you can find Christine. She said you can look on the NAMS site, or do you have a specific site, or do you just refer to the NAMS website?
Yeah, so my website is Empowered Women's Telehealth. You can also find me I have a YouTube channel where I go more into depth about menopause because you're right, there's a lot of information there. So you can find me at Menopause NP for nurse practitioner. So Menopause NP is my YouTube channel.
All right, I'm gonna find you, and I'm gonna follow you
Yeah.
too, as I'm in my mid 40s now.
So one thing I wanted to add is usually one of the first signs of perimenopause is changes to your cycle. So it may be that you're skipping cycles or they're shorter or longer. So maybe 25 days instead of your typical, every 30-day cycle, right? They also might become heavier or lighter. So, and then of course, skipping, if you're skipping cycles, that's a really good indication that you're in perimenopause. So any changes to what you would describe as your normal menstrual cycle is usually the first sign of perimenopause.
Okay, great. That's excellent information. So some people are probably like, okay, I guess I'm in perimenopause. I started with that very early. So yeah, this has been very informative for me as well. Okay, our lawyers make us say this does not constitute a patient-provider relationship. Again, this is not medical advice. If you need medical advice, you can either see us individually or you can see your in-person provider. And thank you for joining us today.
Thanks.